Hey there, Professor Zeeb here. Welcome in to another audiovisual lecture. This time we're going to cover Chapter 8, which is eating disorders. So this chapter actually covers eating disorders and sleep disorders. We're going to focus more on the eating disorders part of the chapter. So let's get started. I'll share my screen here. Okay, so we go to Chapter 8 there, eating and sleep-wake disorders. Okay. I'm going to say right from the beginning that this chapter covers some really sensitive material. So just as a warning there, it is a sensitive chapter, and we're going to be talking about, information that often touches people that we know. Sometimes it touches ourselves. So I just want to prepare you for that it's a kind of a touchy, sensitive type chapter and material, if you will. Okay, so let's get started here. We're going to look at the major types of eating disorders. Really, we're just going to introduce them first, and then we'll get into the more specific details of each one. Okay, so let's get into eating disorders basics. So in terms of the prevalence of these disorders, it has increased in the Western world. So they started to increase around the 1950s and early 60s and then continued. There is some evidence that they are still increasing. However, that's controversial. Not everyone agrees with that. Some people believe that they've leveled off. But we do see some statistics and research showing that possibly they are still increasing. Research also should suggest that it has increased to other parts of the world. So it's not just a Western culture type phenomena. We have seen it branch out into other countries and other areas of the world. So possibly we consider it to be more of a global problem. Okay. So yeah, we have some evidence that it's not just, for example, an American problem. It seems to be pretty common in young Caucasian females who live in competitive environments. So that particular description makes up a large proportion of the cases, but not always. So even though I'm kind of throwing that out there, it does not mean it only affects this population. But once again, we do see a pretty good size proportion fitting that description. So for example, the very famous Princess Diana was one that struggled with an eating disorder, more specifically bulimia. We find it in athletes, for example, gymnasts, different areas, and so forth. So we're going to look at some different research surrounding that. What's kind of scary about this one and very serious about this one is that the mortality rate for anorexia, one of our eating disorders, is the highest of any psychological disorder that we would talk about in a class like this. So it's been estimated that 20% approximately will die from their condition. Typically, that's going to be from, malnutrition and organ failure, but we do see a proportion that also commit suicide. So it is a very serious problem, a very serious condition with like I said, one of our highest mortality rates that we know about in the disorders that we cover in this class. The causes seem to have a large socio-cultural component. In other words, there may be a lot of cultural pressure and media influence to be thin, for example, or to be concerned about your weight. So we do see a lot of evidence of socio-cultural uh, contributors to eating disorders. Okay, so let's just kind of introduce these. And like I said, we'll get a lot more specific with these as we go. So the first one, as an introduction, is bulimia nervosa. So this would be out of control eating episodes or binges, as we would say, followed by inappropriate compensatory behavior. Okay, so a lot of them state that they have no control when they're in this sort of binging period and so forth, and they cannot stop. So we'll kind of take a look at that more closely a little bit later. The second one is anorexia nervosa, which, really an easy way to say it is that it's self-starvation. So here we have the person who's severely restricting calories to the point where it gets dangerous, to dangerous low levels, if you would. Both of these conditions do have an overwhelming, all-encompassing drive to be thin, and so that seems to be what's motivating it, is the preoccupation with weight and being thin, for example. So that does include both of those. Okay, so next we turn to obesity, which is not an official disorder listed in the DSM, but obviously it is a huge problem in our society. Okay, so one of the most dangerous epidemics confronting public health authorities, according to our author, probably because it's connected to so many health problems. We'll look at that in just a second. But in our country specifically, we definitely have a lot of issues with obesity and being overweight. So it is predicted by experts by the year 2030 that 1 in 2 adults will have obesity. So 1 in 2, and then 1 in 4 will be more morbidly obese by 2030. Wow, those are pretty powerful predictions there that we're kind of moving in this direction where it's almost like it's common. It's this sort of the norm that we're seeing in society. We're very, very nervous about this and concerned because it's really connected to many, many different health problems. So some of those health problems include, I'm just going to throw some out because there's a lot, but things like cardiovascular issues, hypertension, stroke, gallbladder disease, respiratory disease, diabetes type 2, muscular and skeletal problems. For example, orthopedic problems where there's difficulty with movement, hormone related cancers, okay, not to mention other problems. So, one of the ways that we sort of look at obesity is we use this thing called the body mass index, okay, the BMI. And we know that the more overweight someone is at a given height, the greater risk to health. So, in other words, the BMI compares your weight divided by your height squared, and that's in kilograms and meters squared, to produce a number which we call your BMI. So, we have found that by plugging in those numbers and using this calculation, we can estimate the person's body mass index, which is controversial because it's not always completely accurate. For example, if you are a weightlifter where you're short and stocky, you have a lot of body weight, meaning muscle in this particular case, but it may be interpreted as body fat. It could be misleading. So we have these charts that we use. And by the way, this chart is for men and women, okay? And this is found in your textbook. But you would plug in your height over here and your weight, match those up, and you would find what you're considered based on our experts' opinion. So underweight, healthy weight, overweight, and obese. So for example, if you were 5'10", remember this is for men and women, and you're 220 pounds, so that would put you at a BMI of 32. So over 30 roughly is considered to be obese. And then, even beyond that, we have sort of, drastic numbers, for example. So we're going to find that you can simply plug your numbers. A lot of people don't want to know this, but you can get a rough estimate of your BMI. Remember, it's controversial because different circumstances may make this misleading. Like we said, the classic example would be like a running back in the NFL where they're a little bit shorter, but they're very stocky in anything but overweight. They're very powerful individuals. And so their BMI would be off the charts if you sort of looked at that. So you got to be careful with this one. It doesn't always accurately apply to every single person. All right, our next disorder that we're going to talk about in terms of eating disorders is called binge eating disorder. So here the person is binging repeatedly, they find it distressing, and then do not attempt to purge. So which shows there's some differences from some of our classic eating disorders that we'll talk about. But like I said, we'll get into that a little bit later. All right, so now we're going to get more specific with each eating disorder. So the first one we're going to look at is called bulimia nervosa, which literally translates to ox hunger, ox as in the animal, an ox, a huge animal. And so it has this sort of nickname or translation. And more than likely, that's due to the excessive binging that we're going to talk about. All right, so let's jump into bulimia here in our clinical description. Binge eating is going to be characteristic of bulimia, meaning a large amount of food is consumed that most people would eat under certain circumstances. In other words, they're eating an enormous amount of food that would be surprising in one sitting, as an example. Typically, it's going to be junk food rather than, say, fruits or vegetables. And so you also have to realize that the actual calories they're consuming varies significantly from person to person. So we don't really have a perfect statistic for this. It's going to be different from case to case. But just to give you an indication of how large a binge could actually be, remember we're saying this is eating an enormous amount of food in a small amount of time. That would be considered to be surprising. So a single binge, get this, a single binge could consist of 20,000 calories. So just to kind of put that uh, in equivalency sort of terms, that is the equivalent of 6 liters of chocolate syrup in terms of the calories. So can you imagine eating a meal that has the same amount of calories as 6 liters of chocolate syrup? I mean, obviously, an enormous amount. Now, remember, that's an extreme example of a binge, but it just kind of gives you an indication of what it could be like. And that does vary from person to person. Bulimia also has to show the feeling of being out of control during the binge period. So the person often reports that they simply cannot stop or control how much they are actually consuming. The individual then attempts to compensate for the binge period because remember, just like with anorexia, we're going to find that this person's concerned about weight and weight gain, and so they're preoccupied with that. So they've eaten this enormous binge, they've gone through this binge period, and now they may attempt to compensate for that, possibly because they feel guilty about the binging experience, or they're worried about gaining weight because they have this, a fear of gaining weight, as we said before. So they're going to employ what we call purging techniques, which are techniques to get rid of calories very quickly. So some of these would include like self purging or vomiting. Some bulimics are so skilled at this that they can actually vomit on command, meaning within a second or two, they can make themselves do this. They may abuse laxatives, for example. Enemas are sometimes used. They may abuse diuretics, which are drugs that make you urinate and sweat a lot. It may be excessive exercising to get rid of calories or going through a fasting period. The point is that these strategies are considered to be, inappropriate, and they're attempting to compensate for the binging period. We're also finding that bulimics show an over concern with their body shape. In other words, their self-evaluation may be based on their current weight. For example, it may be connected to things like popularity and their self-esteem, as well as how likable they are in terms of their body shape. Okay, so there are two types of bulimia. So we have what's called the purging type. So they actually only reduce calories. Oh, excuse me. So in other words, this is the bulimic that uses purging to get rid of calories. And what's kind of shocking about this is that when you purge, let's say that you binged and then you made yourself throw up, it actually, roughly it only reduces calories by about 50%. So a lot of people kind of think that, okay, I'm going to get rid of everything. If I quickly throw it up, all those calories will be gone, but the body still has absorbed it. So usually we're saying it's about only about 50% of the calories are lost through that technique. And if they delay it, then it would be even less. So it kind of depends on the particular strategy, but the point is it's not effective, and it's there's some health risks with that as well. Okay, we also have the non-purging type. So in this case, they may be, exercising excessively or fasting to get rid of calories or to lower their body weight. What the research is showing is that the non-purging type of bulimia is rare. And some studies have shown it's only about 6 to 8% of those with bulimia. However, there's really no difference between the two types as far as severity of psychopathology, the frequency of their binge episodes, prevalence of major depression and panic disorder. So some psychologists question, is it actually, a useful subtype if there's really, if they're kind of, there's a lot of overlap between those two, do we really need two, different types because there's a lot of common denominators there? It's also shown in research that the purging type does seek treatment the most. So as a result of all of that, the distinction was dropped from the DSM-5, our current edition of the DSM. Okay, so our fifth edition has dropped that. So once again, a lot of people believe that we really don't need two types. They're not really doing, they're not very useful to have two. Okay, so now we're going to look at the medical consequences of being bulimic. And I think in this case, we're saying it's a chronic condition. So it's not going away. It seems to be chronic. So some of the, notable medical consequences of bulimia: salivary gland enlargement. This is due to repeated vomiting, right? As we said, could be a part of the condition. And ironically, this one can result in a face that appears chubby because these glands are enlarging. So ironically, someone who's trying to change their body shape, possibly to appear thinner, we see this sort of, side effect or consequence of that. Erosion of dental enamel. So once again, I think in this case, we're assuming that they're vomiting consistently. So enamel, by the way, the hardest substance in the human body, is being broken down or eroded through repeated vomiting. So usually it's the inner surface of their teeth. So for example, you may not notice from the outside, but if you're able to look on the inside of their teeth, we often find that the enamel is being eroded away. So they're vomiting to the point where they're eroding the hardest substance in the human body. Electrolyte imbalance, especially where sodium and potassium are concerned, where those levels are disrupted. That's a huge problem because it could lead to cardiac arrhythmia, which is where their heartbeat is disrupted. It's also connected to renal failure, which is failure of the kidneys, where the kidneys shut down. And so very serious because both of these could lead to death. These could be fatal. So once again, it shows the seriousness of this. Other medical consequences: intestinal problems. Typically, this is from laxative abuse. So if they're Their strategy of choice is to abuse laxatives to make them have bowel movements quicker to get rid of calories. So it can, create problems in the digestive system, including constipation, permanent colon damage, for example. Sometimes we see that they have calluses on their fingers and their back of their hand, and that's from continuous purging. In other words, from the self-vomiting by forceful means. So if they're, using their hand to induce vomiting, it creates the gag reflex, which causes injury at times to the back of their hand. So that's another notable consequence of bulimia. Okay, so now we're going to look at some associated psychological issues connected to bulimia. So anxiety would be one. Okay, so anxiety seems to be strongly related to bulimia and pretty common. So for example, the person, may be diagnosed with bulimia, but also have something like social phobia or generalized anxiety disorder. So those are pretty common. We also know it's associated with mood disorders, more specifically depression. The problem with this is that did okay, so does the depression cause bulimia or does bulimia cause depression? Most evidence, if we look at the evidence, shows that bulimia typically comes first in this particular situation. So even though you could argue that it could go both ways, when we look at the research, most of the evidence is pointing that the person was probably diagnosed as a bulimic first and then developed depression. Substance abuse is another associated psychological problem. Other psychological issues would be emotional instability and novelty seeking. So, somewhat personality factors that we've noted. Okay, so this may account for why we find that it's pretty common for a bulimic to also have anxiety, but also to have substance abuse uh, problems because maybe they're emotionally stable at the same time. They're willing to try new things, for example. So it could explain why we see that sort of connection. All right, so now we're going to move on to our next eating disorder, and that is anorexia nervosa. Okay, so anorexia nervosa is where they put their health in really considerable danger. Okay, so once again, it is a dangerous one. Intense fear of gaining weight to the point where it is dangerous. So, just to kind of give you an example of this one, I remember reading a case study where there was a particular anorexic female, and she was so concerned about consuming calories. A lot of times they may calorie count and be very aware of that she actually would not lick postage stamps because they may contain calories. So back in the day, we used to have to lick the stamp to put it on the envelope before the self-adhesive one. So can you imagine it's to that point where you're actually concerned that if I lick this stamp, it may contribute a calorie or whatever it is. I don't know what it would be, but it may be contributing to that. And so I'm going to avoid that because I don't want to risk that. Anorexia nervosa also shows a successful pursuit of thinness. Some of them are often proud of it, by the way, and often will state that. It often begins with normal eating, but evolves into an obsession, preoccupation with being thin. Some anorexics exercise rigorously with dramatic weight loss to the point where it's almost like a punishment, exercising to the point where it's punishing in some cases. So excessive exercising probably is more of a characteristic of anorexia compared to bulimia, even though we know that some bulimics also do this as well. All right, so as an example, just to kind of show you the effects of anorexia, as we said, it's a very dangerous condition with a very high mortality rate. We're going to use the example of this model. So Anna Carolina Reston, unfortunately, who had eating disorders and eventually died, unfortunately. So she died in the year 2006 at the young age of 21. So as you can see, a model, as you know, a lot of models are very tall and slender and so forth. So she was very young, died of her condition in 2006. And so when she died, they weighed her and they found that her weight was 88 pounds. Once again, a very tall person with a weight of 88 pounds. And so if you remember, we were talking about BMI, her BMI was calculated to be 13.4. So by the way, 16 is considered starving. So she was well below what we would consider to be starving. So it shows that, wow, it's a dangerous condition where it could actually kill someone through organ failure, renal failure. Some of them commit suicide, for example. It's a very dangerous condition. And so obviously, if you know someone that's struggling with this or you're struggling with this yourself, you want to get treatment. You want to try to get help because it can be very dangerous. All right, let's go to our clinical description of anorexia. It's definitely less common than bulimia. So for example, if we look at some statistics that have been produced, bulimia is considered to be about 1%. So the person has a 1% chance of developing it over a lifetime, where anorexia is 0.6% over lifetime prevalence. So it shows that both of them are relatively rare, but anorexia is rarer than, say, bulimia. However, that being said, a lot of people who have bulimia may have a history of anorexia as well. So sometimes there's overlapping factors there. Typically, it's going to begin in adolescence. So that's pretty common for the onset to be relatively young. I think it's late teens, early 20s is typically when eating disorders as a whole sort of emerge. Okay. So it's going to begin in adolescence. We find that it's often people who are overweight who are getting concerned about that initially, right? But not always. Sometimes they're not overweight at all. So it kind of depends. I guess the point with that one is that they may perceive themselves to be overweight when potentially they're not. It's going to involve dramatic weight loss. Okay. And so that's going to be achieved through restricting calories, purging. Okay. So different strategies for doing that. Remember, it could involve an intense fear of gaining weight or becoming obese, for example, and the pursuit of thinness. And like we said, sometimes they exercise excessively to the point where it's almost like a punishment. All right, so let's look at our subtypes of anorexia. So we have the restricting type, where they diet to limit their calories, and then the binge eating purging type, which relies on purging to limit their calories. Okay. So about 50% of them will do that. Now, wait a minute. I know you're kind of wondering, wait, so anorexics can binge too? So wouldn't that be bulimia if they're binging and purging, as we said before? The difference here, so that, if you had to kind of find a difference between an anorexic that binges and purges compared to our classic bulimic, is that the binging is often in smaller amounts. So the binges seem to be pretty small and it's more consistent. So that's really kind of the difference. Once again, there's a lot of overlap here. So between these two disorders, there is a lot of overlap there. Few differences exist between the subtypes as far as severity of symptoms or personality. In fact, it may just reflect different stages or phases, if you would, of anorexia. So maybe they started out as the restricting type, and then they went on to a binge eating purging strategy. So once again, we're not really seeing much of a difference between those two in terms of, the severity of symptoms, personality. It may be just different phases of the same thing. The DSM-5 also sort of states that the subtyping should only refer to the last 3 months because they are thought to be phases. It doesn't really help to predict the future course of the disorder. Anorexics are never satisfied with their weight loss in most cases. So they may stay the same, in terms of their weight every day, even if they're really low, which causes anxiety. So, for example, they may involve themselves with checking their weight several times, repeatedly throughout the day to look for weight loss. So, you know, once again, as we all know, it's hard to lose weight at times, and so they may not be satisfied with their strategies and often check to sort of see what's happening. DSM-5 criteria for body weight is 15% below the expected body weight. However, by the time they actually reach treatment, and by the way, can be resistant to treatment, but by the time they actually, pursue treatment and get involved with that, their weight loss may be 25 to 30% that of their normal weight. So even though the criteria here is 15%, by the time they actually seek treatment, and it's probably much lower, in some cases 25 to 30% of their normal weight, which obviously is very low in that case. Anorexia is marked by disturbance in body image. So the common analogy we use in psychology to kind of explain this one is that they may actually perceive themselves as heavier than they actually are. So when they look in the mirror, it's almost like their perception is distorted to the point, I don't want to say hallucinate, but there's a perceptual issue where they may believe that I am overweight, or they may sort of focus on different body parts that I need to lose weight in this particular area. So this analogy we use, it's kind of like when you go to a carnival and they have those sort of funhouse mirrors. I don't know if you've ever seen that before, and you look at yourself and it distorts you, right? I mean, obviously it's not that extreme, but they may literally perceive themselves differently than how everyone else sees them. In other words, wow, this part of my body is a little overweight. I need to really focus on that. Where everyone that knows them, wow, they need to, they really need to gain weight, if anything. So we think that the way they see themselves, perceive themselves, or think about their body in general is distorted, and there's problems there. Anorexics rarely seek treatment on their own, so very resistant in that sense. Usually it's from pressure from family and friends that you need help, you need to get some kind of treatment here. That's why I'm saying we want to encourage these people to seek treatment because it can be dangerous, as we've said. Many anorexics agree that they need, possibly need to gain a few pounds, but maybe not actually believe that. So maybe they're just kind of saying that, or they don't actually believe it in reality. Okay, so next we go to the medical consequences of anorexia. All right, so amenorrhea is the first one we're going to note here. So this is the cessation of menstruation, which, by the way, can also occur with bulimia. So in other words, they stop menstruating, probably because the body is shutting down, and malnutrition and hormonal imbalances, it creates problems in the body. This one has been been shown to be very inconsistent in anorexia, and actually has been dropped from the DSM-5. So previous editions of the DSM did include this as a diagnostic criteria, but because of the inconsistency, they've dropped it. Okay, other consequences: dry skin, brittle nails and hair, sensitivity to cold. Once again, probably due to lack of fat cells or insulation, lack of nutrition, create that problem. So sometimes we see the development of lanugo, which helps to insulate the body. So these are soft, downy hairs that are often shown on limbs, chest, their cheeks, for example. This is actually pretty common. And the purpose of that is to insulate the body and to trap heat. So this may be the body's sort of response to trying to keep warm because there's no fat cells to insulate the body. So just as an example, you can kind of see it here where we would find that there is this growth of the soft downy hair there on the cheeks. Cardiovascular problems. This could include things like low blood pressure, low heart rate, which could create serious problems. Electrolyte imbalance, cardiac problems, kidney problems. Remember, a lot of these are fatal or can be fatal. So problems with their heart, problem with their kidney, which can result in organ failure, especially if they purge. Next, we're going to look at psychological disorders connected to anorexia. Those would be anxiety and mood disorders, particularly with depression. So very similar to what we would see with bulimia, where there's a connection or association between anxiety disorders and specifically depression. They've also found that anorexia can be connected to OCD, so obsessive compulsive disorder. And if you think about that, it kind of makes sense because OCD individuals have obsessions where they perform rituals or compulsions to get rid of those obsessions. So in this case, the obsession could be, fear of gaining weight or worry, preoccupation with body shape. And so they're doing drastic things to kind of get rid of those thoughts, as a way to alleviate that, at least temporarily. So we do see a connection to OCD at times. Substance abuse is also common. Uh, it turns out that anorexics who abuse substances, it is a strong predictor of mortality and suicide. So this combination of anorexia and abusing substances seems to be pretty dangerous because we know it's a really big predictor, potentially succumbing to their disorder or potentially attempting suicide. All right, next we go to binge eating disorder. Okay, so this is a newer disorder introduced in DSM-5, or in the DSM-5, I should say. Okay, so as the name implies, binging, but also accompanies marked distress, but do not engage in extreme compensatory behaviors that we see like in bulimia. So the binging is there, it creates distress to the person, but they may not necessarily involve themselves in purging, as an example. In other words, they don't have enough here to classify them or to be diagnosed as bulimic. This one tends to occur in males more compared to other eating disorders. So overall, we would say eating disorders often occur in women more. That's been, established in research, but this one seems to occur in males more compared to other eating disorders, I should say. About 50% of individuals with this try dieting before actually binging, while half start with binging. Concerns over body shape and weight, so very similar to bulimia and anorexia. Okay. So maybe they're binging to alleviate bad moods or the negative effect, of weight gain or being in a certain condition. And what's interesting about binge eating is that they often have a better response to treatment, okay, compared to, say, anorexia as an example, and also a later onset compared to our other eating disorders. This one, in terms of the onset, when it first kind of appears in a person, seems to be later than what we would see with the other eating disorders that we've talked about. Okay, let's look at our statistics of bulimia. Majority of them are female. So some studies have estimated that to be about 90 to 95% of the cases. There's a huge proportion that seem to be bulimic males, where they're either homosexual, bisexual, or athletes. So let me clarify. So most of the cases are female, but we do have a proportion of male bulimics that are typically homosexual, bisexual, or involved in some kind of sport where weight is of concern. Okay. So for example, like wrestling would be an example of that, where they have, weight classes and things like that. They're trying to get down to a weight class or whatever it is. Usually develops in late adolescence, but definitely can occur earlier. Okay. So this can occur earlier, but we would expect it to sort of appear early on in the person's life. Remember, the median age value for all eating disorders is 18 to 21. So certainly by college age, we would kind of expect eating disorders to be a concern, but bulimia, of course, can occur much earlier than that. Tends to be chronic if untreated. Uh, some experts believe it's more chronic compared to, say, anorexia. All right, so let's take a look at our statistics for anorexia. The majority of them are females from white, middle to upper class families. As we said, the onset, and this is for all eating disorders, is 18 to 21, but can occur younger. Very common in young adolescent females. Tends to be less prevalent than bulimia. So as we mentioned, bulimia is thought to be about 1% lifetime prevalence. Anorexia, it's 0.6%. However, the numbers do vary from study to study. Tends to be less chronic and more resistant to treatment compared to bulimia. So can be chronic once developed. So once it gets going, but when we compare it to bulimia, we see differences. We also find that they may continue patterns even if they're no longer meeting the diagnostic criteria. So for example, let's say they were diagnosed with anorexia, they've received treatment, some of the symptoms that we would expect subside, they may continue some of these patterns for a long time. So even if they don't technically fit the description or diagnosis of anorexia, they may still continue some of those patterns. All right, we're going to go ahead and stop there. So make sure you check out more information there in Canvas and progress to the next step in the class.